Good morning, everyone. My name is John McElligott. I'm the Deputy Executive Director of the Commissioned Officers Association and our PHS Commissioned Officers Foundation for the Advancement of Public Health. I'll come back on and make some remarks, but right now I wanted to turn this over to our host at George Washington University's Milken Institute School of Public Health, Dr. Rajav Rimal. Thank you very much.
Thank you, John. Good morning, everyone. So I'm Rajiv Rimal. I'm the chair of the Department of Prevention and Community Health. And as the name implies, you can imagine, we do a lot of work in the community, both locally here as well as throughout the country and actually internationally as well, a lot of projects in Africa. And we're concerned about prevention. Prevention is sort of the name of the game for us. And this is a topic, opioid abuse is a topic that in our department, we haven't traditionally done a whole lot of work on this topic, although it's of great interest to us. But Dr. Monica Ruiz is one of the few people who, in our department who is actively engaged in this, and she's done work on this topic in various parts of the world, actually, including here in DC. So this is, I'm really glad that we're having this meeting. So I hope this is the first of many such meetings that we will have on a variety of topics, because I know that the PHS officers work in a wide gamut of public health topics. And just to give you a small taste of some of the topics that are of interest to us, and we have faculty and students working on them. HIV is always a big one, and we have a lot of people working on that. There's also a pretty strong contingency working on maternal and child health, prevention of mortality, both domestically as well as internationally, and many projects in Africa on that topic. There's also a pretty big focus on obesity and obesity prevention as well as treatment, physical activity and diet, smoking. All these are topics that, if in the future you would want to have a dialogue with us on any of these topics, I think we would welcome those opportunities. So I don't want to take up more time. I just wanted to take a minute to welcome you all, and I hope this is a first of many steps in a wonderful collaboration and relationships that we can build with the PHS. So thank you.
Thank you very much. Like he had mentioned, the public health service officers in the country, worldwide actually, work on everything in public health. So today we're here to talk about opioid abuse and substance abuse, tied directly to the Surgeon General report that came out just a month ago, I think on November 17. So I want to thank a few people and provide a few remarks, and then turn it over to Lieutenant Commander Samantha Spindell of the FDA to introduce the Junior Officers Advisory Group and why they care about this talk today. Thank you very much to GW and the Milken Institute for hosting the event. Also to all today's speakers, especially Dr. Ruiz. Thanks for your connections. Thanks for working here. And thanks for connecting us to Andrew and the local organization of HIPS. Lieutenant Commander Deborah Wagner and Lieutenant Colleen Scott are two junior officers in the Public Health Service who on the back end had helped to organize things and connect us to make this possible. Also, Kat Leah from GW, thank you very much for organizing and helping to put everything together for the room space. The PHS Commissioned Officers Foundation for the Advancement of Public Health was established by retired PHS officers back in 2000, 2001, and they wanted to leverage the expertise of active duty and retired officers to promote public health generally. The Board of Trustees, which includes honorary trustees, has among its ranks former Surgeons General, senior leaders from the Department of Health and Human Services, and people who remain involved in health research, teaching, and practice. The foundation's largest event is an annual conference. It's going into its 52nd year, and it will be in Chattanooga, Tennessee, the week of June 6 to 9. So if you want more information about that, the website is symposium.phscof.org. Again, that's symposium.phscof.org. It's about 1,000 to 1,200 public health service officers together with local and state partners, talking about a range of work, and the PHS officers in the room and throughout that conference center will be physicians and nurses and engineers and scientists and all 11 professional categories that are in the public health service, led by the U.S. Surgeon General. I need to say something about Dr. C. Everett Koop. He was a pioneer in the field of pediatric surgery and established the first neonatal intensive care nursery. He was nominated by President Reagan and confirmed by the Senate and served as the 13th Surgeon General from 1982 to 1989. He called for a smoke-free society, stepping up the anti-tobacco campaign, and issuing several reports on the dangers of smoking, all things that have continued to have an impact on our society today. Dr. Koop became the lead spokesperson on AIDS and wrote accurate, comprehensive information shared with every household in the United States, actually penned a report himself that was sent out to every household. Among many other issues he promoted were organ transplantation, the rights of the disabled, and revitalization of the U.S. Public Health Service Commission Corps, which now has about 6,500 or 6,600 officers nationwide. When Dr. Koop died in 2013, the foundation received approval from his widow, Cora Hoag Koop, to establish the Koop Living Legacy Fund. It supports several programs, one of which is today's talk, and we thank Cora for her continued support of the foundation and our efforts to honor the legacy of Dr. Koop. The purpose of this speaker series is to highlight public health topics and to connect public health service officers with non-PHS organizations. We want to be able to show the excellence which resides in the Commission Corps of the Public Health Service, one of the nation's 7 uniformed services. We do this by setting up talks with students, faculty, researchers, and many other health-related organizations. We are looking to host more talks in different parts of the country, so we welcome your suggestions regarding those topics, locations, and those organizations that we can help bring to the table. And we will be coming back to GW. So again, thank you very much for being here, and I'll turn it over to Commander Spindell. Ma'am?
Good morning, everyone. My name is Lieutenant Commander Samantha Spindell, and I am this year's chair for the Junior Officer Advisory Group, also known as JOAG. I really appreciate the opportunity to deliver a few words at this inaugural speaker series. So you may be asking yourself, what exactly is JOAG? We are a group that is chartered by the Office of the Surgeon General, and our mission is to provide advice and consultation to the Surgeon General regarding issues specific to junior officers. Our group is composed of about 400 active members across 9 committees, from outreach to recruitment and retention, and we have 21 voting members. Our membership is reflective of the entire Commission Corps, and we have folks from physicians to engineers that work from Alabama to New York, as well as in other nations. The JOAG has 4 major goals. The first is to serve as a resource and support network for junior officers. The second is to foster the development of junior officers by providing leadership opportunities and promoting professional development as well as high standards of officership. The third goal is to increase the visibility of the Commission Corps. And lastly, and this is what brings us all here today, we support the initiatives of the Surgeon General. Many junior officers work at CDC, SAMHSA, and other federal agencies and are actively trying to tackle this issue of opioid abuse. The CDC provides a large amount of information regarding opioid abuse, such as, and I'm sure many of you are aware, opioids are a class of drugs that are generally prescribed to treat acute pain, for example, following surgery or trauma. However, increasingly, primary care physicians who prescribe about half of prescriptions across the country regarding opioid drugs is to treat chronic non-cancer pain. And unfortunately for this indication, there's little data regarding the effectiveness and safety of long-term use. There are many risk factors for abuse of opioids, and these include having overlapping prescriptions at multiple pharmacies, having a mental illness or substance abuse, living in a rural area, having low income, and taking high daily doses of these drugs. Unfortunately, overdose deaths involving prescription opioids have quadrupled over the past 15 years, resulting in about 165,000 people dying. As a nation, we need to improve how we treat folks with non-chronic pain. We need to prevent the abuse, addiction, and overdose of opioids. This is a problem that requires collaboration among multiple organizations, both in the public and private sector. And this speaker series embodies the need for multiple organizations to work together to tackle major public health issues. I look forward to learning more from our speakers today about what we can do regarding this crisis, and thank you to all those involved in organizing this event, and thank you for being here today. Thank you.
So I'm going to introduce our speakers and then get into it. We have 4 speakers today, and then we'll open it up for questions from the audience. The lineup will be Commander Jinhee Lee, Commander Christopher Jones, Dr. Monica Ruiz, and Andrew Bell. Commander Jinhee Lee, PharmD, is a senior public health advisor in the Division of Pharmacologic Therapies at the Center for Substance Abuse Treatment at SAMHSA, the Substance Abuse and Mental Health Services Administration. She is the managing editor for the first ever Surgeon General's report on alcohol, drugs, and health, the co-lead for SAMHSA's Prescription Drug Abuse Initiative, and the SAMHSA lead for PDMP activities. Prior to joining SAMHSA, Commander Lee was a senior regulatory review officer at the FDA and also previously worked as a clinical pharmacist at the Washington Hospital Center, so she's very familiar with the DC area. She earned her Bachelor of Science degree from the University of California, Los Angeles, Doctor of Pharmacy degree from the University of Illinois, ASHP Pharmacy Practice Residency at Washington Hospital Center, and an Executive Fellowship in Patient Safety through Virginia Commonwealth University. Commander Christopher M. Jones currently serves as the Acting Associate Deputy Assistant Secretary and the Director of the Division of Science Policy in the Office of the Assistant Secretary for Planning and Evaluation. That's within HHS. The division serves as the lead on public health and biomedical science issues and initiatives, including programmatic and policy areas that involve complex and rapidly evolving science and technology. The division is responsible for policy coordination, long-range planning, legislative development, economic, program, and regulatory analysis, and evaluation focused on the HHS science agencies, which are CDC, FDA, NIH, and the Office of the Assistant Secretary for Preparedness and Response, or ASPE. Dr. Jones was previously served as Senior Advisor in the Office of Public Health Strategy and Analysis in the Office of the Commissioner of the FDA, led CDC's drug abuse and overdose activities, and served as Senior Public Health Advisor to the White House Office of National Drug Control Policy. Just came today from another meeting at the White House. Dr. Monica Ruiz, PhD, MPH, is an Associate Research Professor here at the Department of Prevention and Community Health, Milken Institute School of Public Health at GW. Her career has focused predominantly on research pertaining to substance-abusing populations, particularly marginalized populations, such as injection drug users, IDU, that are at greatest risk for negative health outcomes associated with substance abuse and addiction. In addition to expertise in clinical research, Dr. Ruiz has also, she has experience in public policy, particularly in the prevention of legislative education to congressional staff on the effectiveness of syringe exchange programs, on reducing new HIV and HCV infections, and in advocacy activities for the removal of the language in federal legislation that prohibited the DC use of city-generated revenue for syringe exchange. Her current research focuses on examining the epidemic impact of policy change on HIV infection and the linkage to care outcomes. This includes utilization of syringe exchange, addiction treatment, and other harm reduction activities here in the District of Columbia. She's also an investigator on a research project examining HIV and HCV knowledge, attitudes, and behaviors among IDU in Egypt, as well as the cultural and social factors that influence the personal trajectories of these individuals into addiction in a culture where substance use is forbidden and highly stigmatized. Finally, Andrew Bell is the Health and Supportive Services Manager at HIPS, a community-based organization in DC. HIP's mission is to promote the health, rights, and dignity of individuals and communities impacted by drug use, sex use, and/or sexual exchange due to choice, coercion, or circumstance. It is one of DC's 3 providers of syringe service programs, and last year was the largest by volume. Andrew oversees all of HIP's staff-run programs. This includes the syringe exchange program, a drop-in center, an HCV clinic, which is run in partnership with the NIH, as well as a number of HIV-related health programs such as SNS, PrEP, the treatment adherence, and community health work. As HIP's point person for issues related to drug policy, Andrew has helped lead efforts to advocate for expanded naloxone access and to amplify the voices of directly affected people to advocate for their own health. This includes co-founding the DC Naloxone Access Coalition, which has worked successfully with the health department to hasten and improve their pilot program and improve HIP's convene, and helping to HIP's convene, host, and support the Chosen Few, which is DC's first ever drug user organizing group. Andrew came to DC in 2014 from Vancouver, Canada, where he helped to work with the Portland Hotel Society, an organization long at the vanguard of North American harm reduction efforts, including co-administering the continent's only sanctioned supervised injection facility. So we have quite a panel of experts here, and our first speaker, Commander Lee, the floor is yours, ma'am.
Hi, everyone. So my name is Jinhee Lee, and with that nice introduction, I'm from the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. Some people say SAMHSA. It's SAMHSA. And a special thanks to the Public Health Service Commission Officers Foundation for putting this together, for GW School of Public Health for hosting, as well as the JOAG for doing a lot of the groundwork behind the scenes in organizing this event. So thank you for having me here. So I've had the privilege of being the managing editor for the Surgeon General's report on alcohol, drugs, and health. And as mentioned, it was just launched on November 17th in LA. I'm here to provide a very high-level review of the report because it's a quite a lengthy document, not as lengthy as some of the previous Surgeon General's report, but still several hundred pages. So there's no way I can fit that in 10 minutes. But I think that it'll dovetail nicely with the rest of the presentations that the other panel members will be presenting on, even though I'll be going over more a broader substance use, substance misuse, substance use disorder discussion, and they will be focusing more on opioids. Opioids are a substance that is abused. Just so that I have kind of an idea of your familiarity with this recent report, how many of you guys have had a chance to visit the website or look at the report? Okay, great. So a lot that haven't. Okay, so that's good news. So let me just start. Here's a clicker. Let me just start with this. So in terms of the rationale for the report, we know that drug and alcohol misuse and addiction are major public health challenges. The combined yearly economic impact of substance use and substance use disorders is estimated to be about $442 billion. The U.S. is also facing an unprecedented opioid crisis, and we find that nearly 20 million people in our country have a substance use disorder involving prescription pain relievers in 2015, according to our National Survey on Drug Use and Health. That's a SAMHSA data source. And approximately 600,000 people had a substance use disorder related to heroin. Most Americans know someone with a substance use disorder, or may know someone who has lost or nearly lost someone to as a result of addiction. And however, what we find is that substance use disorder treatment in the United States remains largely segregated from the rest of healthcare, and that it only serves a fraction of those who need treatment. In fact, only 1 in 10 receives treatment, and that means that about 90% of people who need help, they're not receiving it. And this is a problem, and it's unacceptable. Our healthcare system has neglected to give the same level of attention to substance use disorders as it has to other health conditions that affect similar numbers of people. And so we need to change the conversation around substance use, misuse, use, and disorders. And this is why it's so significant that the Surgeon General has made it a priority and supported the development of this report. So, and the thing is, just to give you a little bit of history about the report, it was a 1.5-year endeavor. Most Surgeon General reports take about 3 years, and so no one thought we could do it, but they didn't tell us so in our faces. And so after it was said and done, they're like, we didn't think you could do it, but good job. So we are very happy with the product, and we hope that you guys have an opportunity to look at it. There's also an executive summary, which is a synopsis of the entire report that isn't as lengthy and very consumable. So please take a look at it if you get a chance. So in terms of just an introduction and overview of the report, I want you to know that the Department and the Surgeon General had a very specific vision in mind when we were tasked to start the process of developing the report. If you look at previous Surgeon General's reports, the audience is very different than the audience that we have in mind for this report. Previous reports, it was more geared toward an audience of scientists and researchers, so the language wasn't necessarily lay friendly. What you'll find with this report is that we want to reach a broader audience because this problem impacts everyone. Everyone, there are no exceptions. And so when you read it, you'll notice that the language is definitely more lay friendly, and that was done on purpose. Now, the Surgeon General's report, it reviews the best available science. And if you're in the field and you're familiar with substance use and substance use disorders, you're not going to find anything new, right? But this is the first time that we've actually been taking the information and putting it in one place for people to consume it, for those who are interested in the issue and the problem. So the report, it starts off with an introduction and overview, which pretty much sums up the prevalence of the problem and also kind of talks about the organization of the report and the things that you'll find in each of the chapters. Then we go into the neurobiology chapter, the prevention chapter, treatment chapter, recovery chapter, healthcare systems, and then we land on the vision for the future, which is basically the final chapter, summing up the key findings from the previous chapters, and then also providing some recommendations for stakeholders to take action on. So after going into saying how consumable this report is and how lay-friendly it is, you might be asking, why do we have a neurobiology chapter? I have to say, if you have the chance to read it, it's very lay-friendly. This is actually, I think, one of the prettiest chapters because it has a lot of diagrams, and it makes it very accessible, especially if you're a visual person. The reason why we had the neurobiology chapter is that we've collected a substantial body of research over the last several decades, and it helps us to understand that the transformation of the brain is critical to understanding why addiction is a chronic disease and not a result of a moral failing or a character flaw. We also, the chapter then describes the three main circuits in the brain involved in addiction and how substance use can hijack the normal function of these circuits. And again, talking about, addiction as a chronic brain disease with the potential recurrence and recovery. So there is hope. Now, the prevention chapter describes a range of programs focused on preventing substance misuse. It also describes population-level evidence-based policies that are effective. There are over 60 prevention programs and policies that have been shown to prevent substance use problems with rigorous research. This chapter, it discusses some of these and highlights them, and the remainder programs and policies that we didn't have room for, we have in the appendices in the chart form. So many to most people who get treatment for their substance use disorder don't think they actually have a problem, and so don't end up actually seeking treatment. Or if they know that they have a problem, they're not fully aware of what treatment options are available. And so this chapter is great because it describes the scientifically proven clinical activities that are used to identify people who have a substance use disorder and how to engage them into treatment. It also describes a range of medications and behavioral treatments that can help people successfully address their substance use disorder. So recovery affects a huge number of people, but it's rarely discussed. But then, it should be celebrated. And so, there's a lot of confusion about what recovery is and what recovery isn't. There's lots of definitions in there. So the nice thing about this chapter is that it actually describes how we define recovery as well as the number of people in recovery, because I think this is kind of an unknown space. The chapter also reviews services and systems that provide recovery support and the many pathways that make recovery possible. So this is actually our most dense chapter. It's the longest one. It's our health care systems and substance use disorders chapter. What we find, if you read the report or if you're in this space, is that the traditional separation of substance use disorder treatment and mental health services from mainstream health care has created obstacles in successful care coordination, making treatment of the whole person difficult and fragmented. And so this chapter explains why integrating general healthcare, and substance use services can result in better outcomes. It also discusses recent legislation like the Affordable Care Act and the Mental Health Parity and Addiction Equity Act that requires healthcare plans to treat substance use disorders in a more equitable fashion as you do with other health conditions. So then we land on the last chapter, which is a vision for the future chapter, which basically takes a public health approach to addressing substance use misuse, and substance use disorders. And so the first, and then we distill down all the findings that we have from the previous chapters into 5 top-line messages. And so the first key message, is that both substance misuse and substance use disorders affect individuals and communities. And addressing them requires implementation of effective strategies. And the important thing to note about that is that when we expand access, we need to ensure that these programs that we're implementing are evidence-based, and that it falls along the continuum of prevention, treatment, and recovery services. The report describes advances made in prevention science in the prevention chapter. It notes that adolescence and young adulthood are major at-risk periods of substance misuse and unrelated harms. Although we know that substance misuse and substance use disorders can occur across the entire lifespan. Therefore, the second key message is that we need to implement and sustain evidence-based prevention programs and policies to reduce substance misuse and associated health and social problems. Third, again, the separation of substance use disorder treatment from the rest of healthcare has contributed to a lack of understanding about substance use disorders as medical conditions, and to individuals' lack of awareness that they might have a substantial health problem. It's also contributed to a slow adoption of scientifically supported medication treatments by providers. And so a full integration of the continuum of services for substance use disorders with the rest of healthcare could significantly improve the quality, effectiveness, and safety of all healthcare. So fourthly, we know that MAPIA and the ACA have increased coverage for mental health and substance use disorder treatment services for many Americans. Many more people are now able to access care. However, there still remains a great deal of uncertainty about the nature and the range of healthcare benefits available. We need to increase the public understanding of individuals' rights to healthcare for treatment of substance use disorders. We also need to implement screening for substance misuse and substance use disorders within the healthcare organizations. And so then lastly, we have research over the last couple of decades giving us an understanding about the biological and psychological factors associated with substance misuse and disorders. We know more about substance use disorders than we knew about the effects of smoking when the Surgeon General's report on smoking in health came out more than 50 years ago. However, additional research is still needed, and future research needs to be built upon this existing knowledge base. And so the chapter then goes into recommendations for stakeholders and calls on various stakeholder groups to help change a culture, attitude, and practices around substance use. And these are the stakeholders that are identified in the report. They are your individuals and families, your educators and academic institutions, healthcare professionals and professional associations, healthcare systems, communities, the private sector, various government entities, as well as researchers. And so I want to just leave you with this thought, and just in summary, everyone has a role to play in addressing substance misuse and substance use disorders, but this isn't something that can be done in silos, and it's certainly something that can't be done alone. And so the Surgeon General and the department is asking that you partner with us to start the conversation, to change the conversation actually around substance use and substance use disorders, so that we have a society where communities are willing to invest in prevention services, and that we have treatment providers who are willing to give these individuals the same level of compassion as they would for anyone else with a different chronic disease. And so with that, I'm going to actually turn it over to Commander Jones, who will share about what is being done at the federal level, more specifically around opioids.
I'd say thanks for having me here today. I'll be here later tonight for class, so I'm very familiar with GW. So maybe I represent the idea of what you're trying to accomplish of PHS officers collaborating with academia, because I do that. So as Jinhee mentioned, I will cover just a little bit of framing on why this issue is important. You heard some in opening remarks as to why we should care about this issue as a public health problem, and then talk some from the larger Department of Health and Human Services perspective on what we're doing to address this issue. As was mentioned earlier, from an epidemiological perspective, there are large numbers of people who engage in misuse or non-medical use of prescription opioids. This comes from the National Survey on Drug Use and Health. The blue line represents prescription opioids. So 2014 data, just so I could show a trend line here, we see a little bit over 10 million people reporting non-medical use in the past year, and compared to heroin, a little bit over 900,000 people who used heroin in the past year. You can see the trends are a little bit different. As consistent with other research, we have seen some stabilization around prescription opioid misuse in the U.S., but increasing heroin use in the U.S. However, if you dig into the misuse, you actually see that the intensity, frequency, and problematic use of prescription opioids has continued to increase. And that's sort of reflected here when we look at people who have use disorders. So the top line is any opioid use disorder, prescription or illicit heroin. About 2.2 million people in 2014, and 1.9 million of that was prescription opioids, and about 600,000 was for heroin. There are about 300,000 people who meet criteria for both heroin use disorder and prescription opioid use disorder in the past year. And as we have been working on this issue from a policy perspective, it has evolved in the last 5 or 6 years, where earlier in the Obama administration in particular, where there was a focus on this issue, was really much focused on prescription opioids. And the trends around heroin use in the U.S. were relatively flat. The trends for overdose for heroin were relatively flat, and the focus was on prescription opioids, where the data were taking us to prescription opioids as the problem. And as we have continue to work on that issue, we've seen a resurgence of heroin use in the U.S. And what we really see is the populations are quite blended. That about 3 out of 4 people who report heroin use initiated their opioid misuse with prescription opioids. This comes from the National Survey on Drug Use and Health, a study I did a couple of years ago. Other researchers using different data sources, different samples, have found basically the same thing. About 70 to 80% of the people in the U.S. who are currently using heroin initiated misuse with prescription opioids. One point of clarification, I think if you read a lot of the news stories which are focused on heroin, is this idea that people simply move on from prescription opioids, that heroin is something that people have graduated from prescription opioids. And what we really see is there's a lot of gray, and there's a lot of back and forth depending on what is available in a particular community. So in this particular study we did, 7 out of 10 reported both use of both in the past year. And that's pretty consistent with other studies that have been shown. And so it really gets to issues of economics and availability, and really route of use, what people prefer their product to be and how they prefer to use it has implications for what substances they're using. We've also seen the demographics of the heroin population change. So not only have we seen it expand, but it's expanded in ways that we historically had not seen. So we tend to see large increases among non-Hispanic white populations in more rural and suburban areas. We see actually larger or faster increases among women compared to men. We see across income levels, across insurance status, we see increases. So this side was from a vital signs we did at CDC back in 2015, again, where you can see here populations that historically had not been thought of as heroin-using populations, seeing pretty large increases over time. And then Ted Cicero did a paper of people coming into treatment, found very similar things, that actually the line between men and women in their particular sample is essentially 50-50. After 2010, and there was a pretty dramatic difference between non-white versus white heroin use. And when you step back and look at it, what you really see is the populations of people who historically were thought to be heroin users are continuing to use heroin, but the universe of who's using heroin really reflects the populations who have had over a decades-long problem with prescription opioid misuse. And lastly, from an epidemiological perspective, when I was at CDC, this is really what got Tom Frieden's attention, and why CDC started paying attention to this issue, is just a really dramatic increase in deaths. This is death rates for opioids from 1999 to 2014. And this red line is any opioid, so prescription or heroin. And you can see here pretty much year-over-year increases since 1999, almost a quadrupling of the rate over that time frame. This line represents what we would traditionally call the prescription opioid, so natural synthetic opioids, so morphine, hydrocodone, oxycodone, your commonly misused prescription drugs. And this is the heroin line here. Actually, I shouldn't have to use a pointer. I could just be Vanna White and go right to it. So this is the heroin line. And as I mentioned, in 2009, 2010, the beginning of this administration, heroin-related deaths had been relatively flat. Some of that is probably artifact in how medical examiners and coroners document deaths, but we were going off the data that we had, and it was relatively flat. And you see really after 2010 a pretty significant increase. And then between 2013 and 2014, this is synthetic opioids, which is large part illicitly manufactured fentanyl, which is driving this increase. What's interesting is that there were cases of heroin mixed with fentanyl in 2006, and about 1,000 more deaths than we would normally see. And you can see that bump here. And we have seen that, but to a much greater extent in 2013, moving into 2014. And if you read the news, 2015 and 2016 are not looking any better, in particular because of a massive influx of fentanyl and fentanyl analogs coming into the US. But you can see here it's evolved, and our policy response has had to evolve as the issue has changed. And we also see that it's really multifaceted. We have about a decade long of rising rates of hepatitis C, primarily driven by injection drug use and opioid injections, whether that be illicit or prescription opioids. And again, the populations here from the CDC's work on this space is primarily more rural, suburban, non-white, young population, people less than 30 is where they see the increases. So it's almost reversing some of the steps that have been made forward in driving down hepatitis C. Scott County, Indiana, the largest HIV outbreak we've experienced in recent history, over 180 cases. Over 90% of those cases were co-infected with hepatitis C. And what's interesting is that the HIV cases were generally rapidly transmitted among the drug-using population in that county. They were very much genetically related. When you look at the hepatitis C cases, it actually was long-standing injection drug use in the community that was somewhat not recognized, certainly not dealt with, and there are a number of structural interventions which could be implemented in that space and have been implemented in that space since the HIV outbreak. But it was essentially a perfect storm in that community. Very poor knowledge about safe injection practices, no access to treatment, syringe exchange was illegal, and so you have this closed-knit network of injection drug users. It took one case of HIV to enter that, and we saw the outbreak there. We have rising rates of neonatal abstinence syndrome, so infants or neonates who are born physically dependent to opioids. And it's certainly from a HHS perspective, it's important from a state perspective because Medicaid is the primary payer for those births. Please don't ever use the term addicted babies. Just like a pet peeve of mine. They're physically dependent. They don't have the capacity to develop addiction. And a significant economic impact. And Jinhee gave the broader piece on this for substance use, but for opioids, a recent analysis CDC did is over $70 billion a year for prescription opioids. And as I mentioned, the fentanyl issue has really lent, from a policy perspective, a sense of urgency within the administration. The National Security Council actually stood up a policy coordination group to address this, mostly on the law enforcement side, but I'm repping that for HHS to make sure that public health is also engaged in this. But what we see is a large influx of fentanyl and fentanyl analogs, which are super potent opioids, coming primarily from China, being trafficked by Mexican drug cartels. I sound like a DEA agent. So I've been in too many meetings with DEA. But trafficking in fentanyl and fentanyl analogs to the U.S. And I think what's most concerning from a public health standpoint is that the data suggests that low-level drug dealers and users really don't know. So they think they're using heroin, or maybe they think there's some mixing of fentanyl and heroin, and it's just very unpredictable. So they're using what they think is their regular amount of heroin, and they're getting something that's 50 times stronger. And so we see clusters of overdoses in very short periods of time. And from a policy perspective, it really just lends a sense of urgency to scaling up evidence-based interventions. And it is, again, this issue was already very concerning. This just lends an additional sense of concern. Okay, so this is just to distinguish whether or not this was coming from the prescription. So fentanyl is a anesthesia agent, a pain agent that's used for severe pain. And some people were curious to see if what we're seeing in the deaths was prescription fentanyl, and what we see is that we don't, the correlation is with fentanyl submissions that are coming in through DEA. Good question, Marcia. She's on my committee, so I have to be nice to her. From a policy perspective, HHS has been working on this issue for a number of years, but when Secretary Burwell was confirmed, she came in and within actually her first week, she's from West Virginia, has a very personal touch on this issue. She asked for a meeting with all the agency heads, so CDC, NIH, FDA, SAMHSA, CMS, et cetera, to say what are we doing on this issue and how do we really do it more cohesively and strategically from a department perspective. And what came out of that briefing was an initiative that was a focused initiative looking at high impact interventions that really could move the needle with the time that she would have left in this administration. And so it focuses on 3 areas: improving opioid prescribing, expanding medication-assisted treatment for opioid use disorders, and increasing the use of naloxone. So trying to take this comprehensively, appreciating that prescription opioids and the issues around pain management are very much connected to heroin use and the heroin problem in the US. And we can't just focus on changing prescribing behaviors because you have this population of people who are addicted who need treatment. And you need an emergency countermeasure for, such as naloxone to actually give people a chance to get into treatment. If they're, some people would say if they're dead, they can't get into treatment. And so we tried to look at this from a comprehensive perspective. So what have we done in the prescribing space? CDC issued first ever, HHS at least, clinical guidelines on opioid prescribing in March of this year. It includes 12 recommendations, really focused in the primary care setting. We know that most clinicians don't get very much education on appropriate pain management. And so there has just been this over-reliance on the use of opioids. And so the guidelines really try to put some markers down to say non-opioid treatments should be the primary treatment that's used before opioids. If opioids are needed, there should be a clear discussion on benefits and risk. There should be tighter monitoring. We should not be prescribing the high doses that historically have been prescribed. You should be using mitigation strategies like prescription drug monitoring programs, urine drug testing, screening people for misuse both before as well as during treatment. And so those guidelines are now being implemented. We've also made significant investments at the state level through primarily CDC's Prevention for States program, which is really trying to build capacity at the state level around upstream drivers of the problem. So supporting prescription drug monitoring programs, which are systems that clinicians can use to identify if their patients are receiving prescriptions from other providers, to look at insurance strategies and think about parameters around appropriate pain management, to improve surveillance systems. Our public health surveillance systems in this space are really inadequate, certainly not timely, and so making an investment to help states really understand what's the problem and what they need to be doing. We have educational programs that have been released by FDA, NIDA, and SAMHSA. We are looking at clinical decision support through our Office of the National Coordinator for Health Information Technology, and really that has moved into for some years, and Jinhee was very involved in this, we were looking at integrating prescription drug monitoring programs into the electronic health record system so it would be part of clinical workflow. Now they're looking at operationalizing the CDC guidelines and clinical decision support. As for many other chronic conditions, you've got guidelines for blood pressure, high cholesterol, et cetera. The existence of guidelines doesn't change behavior. And so how do we actually get it into the system so that providers can use the information and help guide care? Our Indian Health Service was the first federal agency to make a requirement for using prescription drug monitoring programs when prescribing opioids. They instituted that policy this past summer. VA has subsequently done that. DOD is doing a study to think about it. No dig on DOD. We also released the National Pain Strategy in March of this year, which is the first federal government blueprint on where we want to go with pain. And again, it's a clear recognition that treatment of pain and evidence-based treatment of pain is very much attached to the opioid misuse issue. And again, providers don't get a lot of training on pain. There's issues with access to alternatives. So if the CDC guideline says you should be providing cognitive behavioral therapy and physical therapy and non-opioid alternatives, if doctors don't have access to it or there's no workforce to provide it, then it really doesn't get us anywhere. And so the pain strategy is really trying to move policy and programs forward to address those types of issues. And lastly, we have engagement with the health profession. That was the meeting I was at earlier. Last year, a number of health professional organizations made commitments to the administration on this issue and have really made some dramatic progress in engagement. When I was working on this issue at CDC, the medical community was sort of sitting on the sidelines and saying, we don't really have a role to play here, this is not our problem. And it's been nice to see them engage and really saying, okay, we have to be part of the solution. And HHS has been working closely with them to advance their work. On the MAT side, we've looked at product development. So we approved the first implantable buprenorphine product, Probufene, which is a 6-month implantable product. For many of the medications that are used to treat opioid use disorders, they have different logistical issues. So methadone, you have to get it from opioid treatment program. In many cases, that means daily going to the opioid treatment program. For Suboxone, you have an oral product that is taken daily. Anytime there's a daily medication, there are some people who are non-compliant. It's important to be compliant. So this is something that provides alternatives for some people. It's, as I mentioned, a 6-month product. We raised the patient limit for buprenorphine. So if you're not familiar with this, it's hard to cover this in 10 minutes. But basically, law that was passed in 2000 said that physicians could prescribe to 30 patients at a time when using buprenorphine in the outpatient setting for addiction treatment. It was subsequently revised in 2006 and raised that limit to 100 after you had been a 30-patient provider for a year. And it had been at 100 since 2007. Essentially, there's a clear recognition of a gap in access to treatment versus treatment need. And so we had administrative authority at HHS to raise the limit. So that was raised to 275 this past summer. We've made investments in states through SAMHSA and HRSA and AHRQ to expand access to treatment. As was mentioned earlier, parity is a part of this work as well. We've released FAQs specific to medication-assisted treatment about what's really expected for insurers around coverage of medications. Health insurance expansion, we'll see where that goes, but that has also provided coverage for substance use treatment services to a large population. And then Congress passed the CARE legislation a few months ago, which authorizes a number of grant programs, both within HHS and other parts of the administration. We'll see what comes with funding, but currently there is, in the Cures bill, there's a $1 billion funding, $500 million this year, $500 million next year, primarily for treatment, which was part of the president's budget request and would authorize funding primarily through SAMHSA to really build the treatment infrastructure in the U.S. And that was, from a policy perspective, the administration really laid down the marker with their budget this year. I don't think when we were writing it, we ever thought we would get it. But it was really to say something has to change in our treatment capacity in the U.S., that we have too many people dying. There's just not enough evidence-based treatment, and we need to make significant investments that are commensurate with the problem that we're experiencing. So I think the Senate is voting on that today. Hopefully we'll have good news, and that will create a lot of more work for Jinhee. And then in the naloxone space, I think as a pharmacist, this is one area that is very much of interest to me, because I think it's really a new opportunity for pharmacists to engage in this space. But it has been a very rapidly changing state-level policy to allow naloxone to be distributed more so through community pharmacies than historically, where they were distributed through harm reduction programs or community-based organizations. So this is just a map of states that had naloxone access laws. 2011, you can see just a handful of states. By 2016, almost all states had some form of naloxone access law. Many of them are operationalized as allowing you to go to the pharmacy without a patient-specific prescription to get it. It's sort of termed OTC. It's not technically OTC, but like you can go to CVS and get a flu shot in Washington without going to your doctor. You could, in some states that have these laws, you could go and get naloxone for yourself, or if you're concerned about someone else, or you think you may be in a situation where you're witnessing and could respond to an overdose. So it has been a really rapid expansion at the policy level, and we see it reflected in the data. I didn't put it here, but we did a study a couple of months ago in American Journal of Public Health where we looked at community pharmacy dispensing of naloxone. And you see for about 3 years, up until about 2014, it's flat. Virtually very little naloxone is being distributed. And then you see this exponential increase. And it has, even since that study came out, continued increases in naloxone coming through community pharmacies. And so it's an opportunity not only to dispense naloxone, but to engage in a harm reduction conversation, to engage in a conversation about opioid safety. I think it makes it very real for people when you say this medication that's being used to treat your medical condition could kill you. And it makes people think about, is this the right thing that's for me? And if it is, how do I mitigate that risk? And naloxone can be a part of that. And if it's not, what alternatives might I discuss with my physician or my healthcare providers about? Similar to MAT and opioid prescribing, we've made investments in states to build out their naloxone programs and, again, supporting state-level efforts to do that. One other piece from a research perspective, we did an inventory this past summer because I was tired of people from CDC saying, wait, I'm already doing that study. And I'm like, wait, but that was on my list when I was at CDC. So I said, we need to have, everybody singing from the same page at HHS, but also there are many other researchers who are interested in this space. And so collectively saying, here's what we're funding extramurally, here's what we're doing intramurally in the pain space, and the prescribing space, and the treatment space, and the naloxone space. So we created a webpage that basically provides a bit of a synopsis for each study that we're doing within HHS, and that's just a resource. If you're thinking about dissertation topics or other things, you could go there and see what people are already doing. So to wrap it up, obviously a very large public health issue. There is a tremendous sense of urgency to addressing this issue, and we've taken a number of steps within HHS to do that. But as Jinhee said in the broader Surgeon General's report, there really is an opportunity for everybody. And when we did the heroin vital signs, Tom Frieden's sort of continual talking point was this is an all-of-society approach. And that, whether it be talking about stigma, normalizing that addiction is a medical condition that people deserve treatment, whether it's, educating people about pain management or naloxone or syringe services programs, we all have a role to play, and we can engage regardless of where we sit. So thank you very much. I'll turn it over to Dr. Ruiz, who will...
Thank you very much, Commander Jones. So, as you can tell, we've gone from the very high level with the Surgeon General report down to somewhat lower level with HHS and what's going on. So we're going to go to, excuse me here, your professor here at GW, Dr. Monica Ruiz, and we'll close up with discussion about what's going on in DC.
Great, thank you. I'm going to try to get this to do full screen. There we go. Awesome. Great. Thank you for having me here today. Thank you for asking me to be a part of this. I'm here to talk a little bit about some of my research, which shows why harm reduction is an essential portion of the national strategy to address this issue of opioid addiction and use. We've already heard about the Surgeon General's report and some of the recent findings about the increase in opioid use, including heroin and prescription opioids. And prevention and treatment are essential pieces of this. Let it not be mistaken that prevention is critical. My degree is in preventive medicine, so this is what I preach and I breathe, eat and breathe day in and day out. Treatment is so important as well, and that cannot be underestimated about how important treatment is. We also know that treatment is underavailable. Treatment is not the right thing for everyone at the right time, which is why harm reduction is an important piece of this strategy. And harm reduction, for people who aren't aware of what harm reduction is, this is a practical set of strategies that help to reduce the negative consequences of drug use and other activities. It incorporates a whole wide variety of approaches. There's no universal definition of harm reduction, but I highlighted a couple of the things that are really critical here. And one of the critical pieces is that we focus on reducing the harms associated with the behavior. When we think about seatbelt use, seatbelts are harm reduction for being in a motor vehicle and riding or operating a motor vehicle. This reduces the harm in case we are in an accident. Similarly, we can focus on reducing the harms associated with injecting drug use by trying to address how do we do this more safely? How do we deal with things in case of potential overdose with naloxone, et cetera? And the other piece of this that is really critical is that it is a client-centered approach. It really strives to meet people where they're at in the course of their addiction. When people are in the throes of addiction, they may not be ready to quit. They may not realize they have a problem. They may want to quit, but don't have access and may have to wait for months and months and months to try to get even a chance at a spot in a treatment program. And so in that meantime, while those people are in that transition period, there are still things that we can do to meet people where they're at in the course of their addiction to reduce the harms associated with use, and do so in a way that is non-judgmental, that is open, that is honest, that is, that avails them of their dignity as people with a medical condition. And this is where we get into the need for structural interventions. Most of our prevention work in the United States, especially around HIV/AIDS, which is my area of expertise, has focused on individual level interventions. How do we change the individual's behavior to get them to do X, Y, and Z, to get them to reduce harms of X, Y, and Z? But structural interventions are equally as important, and because we can only go so far with individual level behavior change. Structural level interventions try to change the environments in which people live and in which those health risks occur, without necessarily trying to change the individual. And so this is where we are referring to policies and programs that create environments that facilitate people doing the things that they need to do. And structural interventions can include policies. So for example, we talked about the policy in the District of Columbia that did not allow DC to use its own municipal revenue for syringe access programs. That was a policy that Congress imposed on the District of Columbia. That was not the choice of the District of Columbia, but that had an impact on the district in a time when 20% or more of the HIV infections were driven by injection drug use. So if our policies don't allow us to create an environment where we can try to reduce these harms, try to address these issues of opiate addiction. And so one of the most well-known interventions and structural interventions for injection drug use, for opiate addiction, for any type of substance use is needle exchange. And the first needle exchange programs made their first appearance in 1983 in Amsterdam after a local pharmacy refused to sell sterile needles to injection drug using populations. In the United States, they first appeared in the late 80s in Tacoma, Washington, Portland, San Francisco, New York City, and since the implementation of syringe exchange programs, HIV incidence in injection drug users in the United States has dropped by approximately 80%. That's huge. That is enormous. Injection-related transmission is the only category of HIV infection among adults that have shown declines of this magnitude. And as you can see, it can be as simple. There's Dave Purchase, the god of needle exchange programs in the U.S. Dave Purchase with the little table and the bucket of sharps. There's the vans that we have. HIPS has a van, the mobile outreach van. It can be complex, it can be simple, but it's so elegant in its simplicity, in its effectiveness, and it's one of the simplest and most cost-effective interventions for HIV prevention and for addressing substance use in communities. And it is not associated with negative consequences such as increased crime rates or increased illicit drug use. And I think that's an important point to make because there's a lot of stigma around these programs and people believe, oh, well, it's going to increase crime, it's going to do this. Research has shown none of that. The evidence shows absolutely no negative consequences to that effect. If we look at the number of syringe exchange programs in the United States, according to the North American Syringe Exchange Network, there are approximately 194 syringe exchange programs operating in more than 33 states, DC, the Commonwealth of Puerto Rico, and the Indian nations. And these are only the ones that are known, that are quote unquote above ground. There are probably more, I would hope that there are more, that are underground that are not known in these areas where it might be illegal, where it might not be as, let's say, socially sanctioned. And so one of the things we do know about this is that there's underutilization of syringe exchange programs. We actually do need more of them, especially given the size of the opioid epidemic in the United States. And modeling studies have shown that widespread syringe access to active injectors for HIV prevention would have societal benefit and would cost less than the estimated lifetime costs if those people were to become infected. And so one of the things that I did in DC as part of my research is to look at the impact of that policy change, that structural intervention that occurred when finally the DC ban was removed. When finally we got that ban removed and we were able to do something about the epidemic in the district. And following that policy change, the then Mayor Fenty, allocated money to the Department of Health to expand syringe exchange programs, to create a network of harm reduction providers, HIPS being one of them, in the district. And so I wanted to see, does this structural intervention actually work? Did it have an impact on HIV in the District of Columbia? So this is, helps if I press the right button. So this is the study. And this just to, pretty slide, this is just to show you the timeline of when things happened. We are also in the course of my study looking at policy change in Baltimore and Philadelphia, also required changes in legislation for syringe exchange programs to start in those locations. I'm going to show you the DC results today, but we looked at the first 2 years of surveillance data following the policy change, because we were doing interrupted time series analysis and looking at the association with the removal of the ban to changes in client services, client access, and modeling out the number of infections that would have occurred had that ban not been lifted. We know what they are because of surveillance data, but we wanted to model what would it have looked like had things not changed. And so we did the interrupted time series analysis, and we found some really fascinating things. What we found is that we would have forecasted approximately 296 HIV infections. Had the ban not changed, we would have expected, given the current trend of infections in the district that are driven by injection drug use, we would have seen 296. What we actually saw from the surveillance data was 176 observed IDU-associated cases of HIV infection in the 2 years following this policy change. This was controlling for other things happening, testing initiatives, those other types of things that might have driven testing in this population and therefore new diagnoses in this population. And so controlling for all of those things, this difference of actual versus expected, 120 averted HIV infections that can be associated with this policy change in 2 years only in the District of Columbia, which is huge. This is huge. And when you think about what this means in terms of treatment costs, we did some modeling to look at the average lifetime cost of treatment as estimated by the CDC in 2010. They estimated $380,000 for lifetime cost for HIV infection. If we multiply that by the 120 cases of averted infections, we've essentially saved ourselves almost $46 million in 2 years. Even if we subtract the operating costs of the syringe exchange programs in those 2 years, we still have about $44 million in savings. Savings to the taxpayer, savings to the healthcare system, and think about the savings to those people who are not infected. These costs do not take into account HCV treatment, mental health treatment, any sort of, this is just HIV care. But what it does tell us is that this saves money. This is not cost-effective, not only cost-effective in terms of a prevention intervention, this is cost-effective in terms of the broader scope of health care in the district. When we think about this in the broader picture, the broader scope of health care in the United States. And so what our data show, I'm going super fast because I know we're low on time, I'm going super fast, but what our data show is that we finally have quantitative evidence of the epidemic impact of policy change, which is, for me, huge. This is the kind of study that I love to do. And we do have evidence that policy change as a structural intervention can have substantial health outcomes. And this is really critical when we think about the importance of public policy and evidence-driven public policy. We want to see that it actually has an impact on people's lives and saving lives. That's the broader goal here for public health. And our data do support the broader implementation of structural interventions as part of a comprehensive strategy with treatment, with prevention, with naloxone prescription and dispensation, with changes in drug prescribing for healthcare providers. All of this is part of a comprehensive strategy to address the problem of substance use and addiction in the United States. The key takeaway point here is that policies can change. And this is the thing we are always worried about as researchers, as advocates, as people who care about this issue. It took 10 years for the DC ban to be removed. We still have a federal ban. Fortunately, it's been changed so that we can actually use some of that money for other program costs, although not for syringes. But these policies can change. And so this is constantly a moving target. That's why it's so important to make sure that we use our research evidence to the benefit of public policy, to the benefit of public health, to the benefit of keeping the American people healthy as part of our vision to address this issue in the U.S. I have a quick slide of acknowledgements. These are all my partners, including HIPS, and I'm going to, at this point, thank you very, very much. This is my study. If anyone wants more information, I'd be happy to share it with you. I'm going to turn over to Andrew.
So please stick around. We have one more speaker here, Andrew Bell from HIPS, who will be talking about what's been going on the ground level, what's happening here in DC. And stick around for the food afterward. We hope that before you leave today, you're going to walk away building some professional relationships with federal folks at the very highest level, developing policy. You have some more ideas about research you could be doing here at the university, and have some partners with the local organization. Andrew.
All right, y'all, I don't have any fancy pictures, unfortunately. And I'll try to go quickly so that we can have a bunch of time for questions. Thanks to Monica for giving you guys a bit of background already on the impact of syringe exchange policy change in the district. HIPS is currently, I'm going to do mostly three things. I'm going to let you guys know who's doing syringe exchange in the district and what that looks like. And then two efforts that we've made around local policy change, either like nascent and early stages or that's had some impact and had some success. So what syringe exchange looks like in the district is there are three organizations that are doing it right now. HIPS, Family Medical and Counseling Services, and Bread for the City. There's a variety of different models employed. So HIPS and Family Medical are the ones with the largest footprints. We sort of trade off year to year on who's doing the largest volume. They do a rotating fixed site, and what that means is they have a van that is expected within the community at certain places at certain times. So they know at this corner they can expect the van for a few hours, and folks are able to go and access it there. They also have a short on-site exchange on Fridays. Bread for the City has the smallest footprint, but also had long been the only provider of naloxone in the city functionally, and we'll talk a bit more about that a little later. They have two locations that provide a broad array of services, and they do wonderful work. Their syringe exchange is located in their medical clinic in their northwest location. HIPS was founded in the early 90s as an organization serving folks actively engaged in sex work. About 15 years later, there was a local organization called Prevention Works, which did syringe exchange. They folded, and there was a need for another organization to step into that space. So HIPS did that in, I believe, 2009. And since that time, we have been operating on a delivery and rolling model, and what that means is we have specific clients in different quadrants of the city who will expect a call from us on a certain day of the week, assigned to their quadrant, and we'll say, hey, we're going to be in your neighborhood today. Do you need anything? And we're able to go and provide new syringes and also dispose of used ones. So that is one of four ways that HIPS does syringe exchange, is our deliveries. The second one is rolling, and what that does is our van in between deliveries, when we're in a specific part of the city where we know there's an area of high activity, we will go there. So it's similar to what Family Medical does with rotating fixed site, but there isn't a set time on it. They're not going to know that we're going to be here at this time. They're going to know we're going to be here sometime on this day, maybe. And the third way that we do syringe exchange is an on-site exchange. So we run a drop-in center that provides a variety of services. It's funded as a trans wellness center, as an organization that serves folks involved in sex work. We have long been very close with the transgender community, who is overrepresented because of a variety of structural factors that I'm sure many folks are aware of. We run a syringe exchange both for folks who are using needles to use drugs and for folks who are using needles for hormones. And our on-site exchange is open when our drop-in center is, which is 10:30 to 5:30 Monday to Thursday, and then in the afternoons on Friday. The last, and I think the most dynamic and important and way that we employ syringe exchange and needs expanding is through secondary exchange. So you have folks for a variety of reasons, many of them again structural, who wouldn't access a public health program. They wouldn't go up to a van that's in a certain place. They're not going to go into a medical clinic. There are going to be reasons they're not comfortable self-disclosing as using. There's going to be reasons of stigma and trust and other reasons as well. Also just reasons of transportation access. And secondary exchangers are folks from the community who exchange large volumes on a monthly basis and receive a small stipend for doing that. So we have 4 secondary exchangers, each of whom exchange between 1,000 and 2,000 syringes per 2-week period. So our secondary exchangers exchange about 10,000 syringes a month. And they are able to access places that we can't. There are places, for example, if there's a shooting gallery where there's a place that folks are using together, they probably don't want to call the van and disclose where they are for predictable reasons. So they're going to have reach for folks who are even more marginalized and even more hard to connect with than connect with the programs. So those are 4 ways that we do it. Some quick numbers. Last year we distributed 350,000 syringes over a grant deliverable or expectation of 200,000. We collected 338,000 over an expectation or a requirement of 185,000. We distributed 388,000 pieces of safer injection equipment over an expectation of 75K. And the reason the contrast is important, it's not so that we pat ourselves on the back, but because we're run by a grant, we're actually victims of our own success and spent last year's really straining against our budget to be able to continue to do this because the supply is still cost. So if we're giving out more of it, it creates serious challenges. Some of those safer injection equipment, for folks who don't know, the syringe sharing is the most dangerous piece of equipment you can share, but sharing a cooker can still result in HCV transmission. HIV, as many folks will know, doesn't live in the air, so there's different ways that the equipment needs to be sterile, and not just as a matter of infection transmission, but also as a matter of plain infection. So one of the numbers that is harder to quantify and not used in presentations about cost savings related to syringe exchange, but no doubt exist, is serious infections that result from abscesses. When you're putting something under your skin in difficult circumstances, you're more likely to get infection. And if you're leading a pretty complicated life, that infection might continue and result in serious health complications or death. So that's some of what we do. That's some of what syringe exchange in the district looks like. The reason I wish I did have pictures is because I could share a picture of Maurice Abbey Bay, who sometimes gets confused for George Clinton at community events. He has been our syringe exchange specialist for 4 or 5 years, starting out as a secondary exchanger. And the way that these programs generally work is they're built on trust and relationships. So someone who is known in their community, someone who folks have had a uniformly positive experience of, is going to be much more successful than someone who is fresh out of school and doesn't know the community. So that's a bit of what it looks like on the ground. Very quickly, 2 sort of policy change attempts that we've undergone. There was long promised a pilot program for naloxone distribution in the district. It was an article in the city paper summer of 2015 saying that this has been promised for 3 years and trying to increase the pressure. The obstacle was a medical director at HOSTA. He arrived in November. We were promised that the paperwork was on his desk, ready to go. And because this had been promised for such a long time, we wanted to coordinate the efforts to increase the attention to it and increase the urgency. So we started contacting our partners, other providers, our partners in academia, our partners in advocacy, and started something called the DC Naloxone Access Coalition. It involved a sign-on letter. It involved sitting down with the health department to explain why this has to happen quickly and what ways it will be most successful. It was able to start in April of 2016. We have since done 264 trainings on naloxone through the pilot program. That's exclusive of other ways we've been able to access naloxone and give it out through our HCV clinic and other things. And that is reflective of 405 kits. So if someone is trained, they're able to get a restock without retraining. And we've had over 50 reversals reported, but that reporting is, we're very confident, way under the number that have been reversed. For obvious reasons, that's difficult, more difficult to get an accurate read on. So that is the other way that we have advocated for expanded naloxone access. Is there was a bill that came through council, which we worked closely with the soon-to-be former council member Alexander's office on, that would allow for third-party prescription and standing orders. And those two things are kind of, other than plain over-the-counter, they're the gold standard for expanded naloxone access. It allows doctors to not just prescribe it to the particular person that's there, but to prescribe it with the knowledge that the person will then provide it to someone else. And the standing order allows people to not self-disclose to their own doctor, but to be able to operate under a larger umbrella. So out of that process, the health department in DC went from not thinking that it was an issue of urgency that we were describing, to being in a reactive mode after there were a number of deaths on Independence Day weekend, and the numbers that they were seeing, they have about a 90-day turnaround through the medical examiner's office. So what we're going to hear on the ground is going to be less precise, but sooner. It's going to be the canary in the mine in terms of what's going on. So they are in the process of forming an overdose response program. They approached us about how it would be successful, and we just repeated again and again that for it to be successful, it needs to be as community-based as possible. Out of that, several of our clients and several of our secondary exchangers were interested in serving their own community. They went to a couple of health department meetings, and after that, they wanted to meet on their own. So the last 2 months, a group that chose the name for themselves, the Chosen Few, have been meeting to talk about drug policy and how they can stand up for their own community. In most cities in the world, including in America, where these efforts are further along, a great part of that is directly affected people organizing together, whether that's the Urban Survivors Union in Seattle, whether that's Vandu up in Vancouver in Canada, or Vocal and other organizations in New York. So that's a very nascent effort in DC, and also DC faces structural obstacles to policy change. Like there are cities where a supervised injection facility has momentum and may open. DC is not going to be that city because Congress is able to govern what we do with our funds. So that group has set its sights on law enforcement assisted diversion, which is a successful program run out of Seattle, which before drug courts, before going into the system, you're able to be connected with a case manager who helps work with you on the goals that you set for yourself. And that's shown a reduction in recidivism and a reduction in an increase in treatment access and use cessation and other things. So that is what's going on the ground in the time that I don't have.
Well, thank you so much for those comments. That's a nice intro to the closing remarks that I prepared. I want to thank all of our speakers. We really appreciate you being here today. It was incredible to learn about all of your perspectives from the federal agency, from academia, and from a community organization. It's very clear that we need to work together in order to make a dent in this problem of opioid abuse. So there are a number of takeaways that I heard, and I'd like to share from our speakers. One is that we need to improve the practices of prescribing these medications by engaging better with our healthcare communities. We need to work with educating patients. We need to change the culture, attitudes, and practices. Another area is to implement state drug laws, as well as drug prescription monitoring programs. Expanding medication-assisted therapy seems like a terrific benefit as well. In addition, we need to improve the detection of illegal opioid use, such as heroin and synthetic fentanyl. Access, of course, to naloxone, we heard from all of our speakers, is a very important aspect to reverse the effects of opioid overdose. And then, of course, on the policy level, having structural level interventions to change the environment in which the health risk occurs is important. We heard that needle exchange programs as well as secondary exchange can really have an impact. So I have a number of thank yous. I would like to, of course, thank the Commission Officers Foundation. Thank you so much for laying the groundwork for this event, particularly John McElligott. There are a number of folks on the JOAG side that contributed to this effort, Lieutenant Commander Wagner and Lieutenant Scott, as well as the professional development co-chairs, Lieutenant Commander Kane and Lieutenant Commander Nelson. I'd also like to thank the former chair and vice chair, Commander Garza and Lieutenant Commander Halden. They began last year with the planning for this speaker series that we attended today. Of course, I'd like to thank George Washington University and the Milken Institute of Public Health for hosting this event and having this wonderful building for us. We look forward to hopefully having additional speaker series here in the future. Thank you, everybody, in this room for attending. Let's continue to work together. Thank you.